Second white coat. Subscribe and like. Let's learn medicine together.
Welcome back to The Explainer. Today, we're literally putting on our medical detective hats because we are going to master an absolutely must-know clinical reasoning pathway. We're going to look at a classic patient presentation, break down the physical clues, examine the forensic evidence from a kidney biopsy, and methodically nail down the exact diagnosis. By the time we wrap up, you are going to be able to spot this disease pattern from a mile away. Here's how we're going to break it down today. Section 1, breaking down the stem. 2, decoding biopsy forensics. 3, the pathogenesis pathway. 4, eliminating wrong answer choices. And finally, Section 5, the ultimate exam shortcut. Let's get right to it. Section 1, breaking down the stem. Okay, let's dive into this. Every great medical mystery starts right here, with the patient presentation. You know, the classic question stem. So here's our raw data, our suspect profile, if you will. We've got a 37-year-old woman coming in with worsening leg swelling over the past couple of months. She's excessively tired, and she's got this achy pain in her hands. On exam, her blood pressure is definitely elevated at 156/92. She's got 2+ pitting edema in her legs, and her bilateral finger joints and wrists are mildly swollen and tender. We run some labs. Her serum creatinine is elevated at 1.8, and her urinalysis, well, it absolutely lights up, positive for both proteinuria and hematuria. Our job is to figure out the underlying cause. Okay, so what does this all actually mean? We've got to translate these raw clues into clinical syndromes. Hematuria means blood is leaking from an injured glomerulus. Proteinuria tells us the filtration barrier is damaged. That 1.8 creatinine, that's active renal insufficiency. And the hypertension and leg edema, that's just the fluid and sodium retention from her failing kidneys. You group all the renal stuff together, and you've got our first major clinical syndrome, glomerulonephritis. Furthermore, mildly swollen and tender finger joints in a 37-year-old woman isn't just everyday wear and tear osteoarthritis, this is inflammatory arthritis. So right off the bat, before we even peek at a biopsy, this combination of a young woman presenting with both inflammatory arthritis and glomerulonephritis should immediately trigger your suspicion for a systemic disease, specifically systemic lupus erythematosus causing lupus nephritis. But we need hard evidence to prove it. Moving right along to Section 2, decoding biopsy forensics. We strongly suspect lupus, but to really confirm it, we need to analyze the heavy forensic evidence pulled directly from a kidney biopsy. Now, what's really fascinating about this finding is the visual analogy we use in the pathology world. When we take this patient's kidney tissue and use direct immunofluorescence to look for immune deposits, the glomerulus literally glows. It's a granular, diffuse, global staining pattern. And it doesn't just light up for one random antibody, it lights up for everything. It's exactly what we call the full house pattern, just like a winning hand in poker. So let's break down exactly what makes up this pathological full house. You know, in poker, a full house is 3 of a kind plus a pair, right? Well, in a kidney biopsy, our 3 of a kind are 3 immunoglobulins, IgG, IgM, and IgA. And our pair consists of 2 complement proteins, C3 and C1q. When you're reading a pathology report and it explicitly lists positive staining for all 5 of these, IgG, IgM, IgA, C1q, and C3, bam, that is your smoking gun. Finding all 5 deposits is incredibly characteristic of lupus nephritis. Section 3, the pathogenesis pathway. Now, we don't just want to memorize buzzwords, we want to really understand the why. Why does this full house happen? Let's reconstruct the crime scene. Let's look at the mechanism and see how this builds from a microscopic glitch into systemic organ failure. Step 1, SLE fundamentally starts with a loss of tolerance to self-antigens. The immune system literally gets confused and starts attacking the body's own nuclear material, especially double-stranded DNA. Step 2, this triggers autoreactive B cells to pump out polyclonal autoantibodies. Step 3, these antibodies bind to the antigens right in the bloodstream, forming these large, heavy immune complexes that eventually get filtered by the kidneys and trapped in the glomeruli. And Step 4, this is absolutely crucial. Once they're deposited, these complexes activate the classical complement pathway. Because it's the classical pathway, it chews up and deposits early complement proteins like C1q right along with C3. This massive inflammatory cascade is exactly what physically damages the kidney and gives us that glowing full house IF pattern. To truly master this disease, we have to know exactly where these complexes land. Electron microscopy in this scenario will show abundant subendothelial electron-dense deposits. Let's demystify that term. Subendothelial simply means these immune complexes are sitting anatomically right under the endothelial cells of the glomerular capillary wall. Why is that specific spot such a big deal? Because it puts these highly reactive complexes on the blood side of the basement membrane. They are in direct, totally unimpeded contact with the bloodstream. And here is the so what of that location. Since those subendothelial deposits are touching the blood, circulating inflammatory cells, like neutrophils, can easily see them. The neutrophils rush right into those capillary loops to attack the complexes. When you look at this under a standard light microscope, the capillaries look absolutely stuffed full of inflammatory cells. Pathologists call this endocapillary hypercellularity. So the electron microscope tells you exactly where the deposits are, and the light microscope shows you the resulting riot of inflammatory cells rushing in to fight them. It all connects perfectly, doesn't it? All right, Section 4, eliminating wrong answer choices. We've built an airtight case for lupus nephritis, but a huge part of clinical reasoning is actively disproving the distractors. Let's systematically clear these innocent suspects by comparing them to our findings. First up, granulomatosis with polyangiitis, or GPA. Yeah, it causes glomerulonephritis, but it's famously POWC immune, meaning little to no IF staining. That's the exact opposite of our glowing full house. What about group A strep? Post-strep GN causes a nephritic syndrome, sure, but its biopsy typically just shows granular staining for IgG and C3, not all 5 markers. Plus, it follows a throat or skin infection, not inflammatory arthritis. Multiple myeloma. That causes kidney failure through light chain cast nephropathy, so you'd see monoclonal light chains, definitely not a polyclonal full house. And finally, rheumatoid arthritis. The test writers love throwing this in because our patient has tender wrists, but while RA causes joint issues, glomerulonephritis is incredibly rare in RA. It certainly wouldn't give you this classic renal biopsy picture. And that brings us to Section 5, the ultimate exam shortcut. We've done the deep physiological breakdown, we've eliminated the distractors, so now let's distill all this hard work into a razor-sharp reflex. This right here is your mental checklist. When you're reading a case and you see these specific puzzle pieces snap together, a young or middle-aged woman presenting with new-onset inflammatory arthritis paired with new-onset glomerulonephritis, so hypertension, hematuria, edema, high creatinine. And the biopsy drops that full-house immunofluorescence. The translation should be instantaneous. You are looking at systemic lupus erythematosus causing lupus nephritis. So, the absolute crucial point I want you to take away from this explainer is this. Memorize the poker hand. Whenever you hear the phrase full house in a renal pathology context, IgG, IgA, IgM, C3, and C1q all lighting up together, it is lupus nephritis until proven otherwise. Hardwire that association into your brain. But before we go, let me leave you with a question to chew on. What if this exact same patient presented with these symptoms, but her biopsy only showed subepithelial spikes and domes instead? How would your diagnosis change then? Think about it, keep connecting those dots, and we'll solve that mystery next time.